We go on to our next speaker, Dr. Pradeep VYAS, who's heads the Center for Sight at Indore, and his subspecialties are cataract and glaucoma, and a very experienced surgeon. And he's going to talk on a case with neovascular glaucoma. On to you, Dr. Pradeep.
Thank you, Dr. Chitra, and thank you, ARC, for this opportunity. Good evening, everyone. So I would be talking on the neovascular glaucoma. And we know that it is one of the most frequently encountered secondary glaucoma in our practice. And simultaneously, it is one of the most difficult secondary glaucoma to treat in our practice. So what is the mechanism for the neovascular glaucoma? It is basically because of the retinal ischemia, which causes the release of vascular endothelial growth factor. And there is an angiogenesis, that means that the formation of the new vessel over the iris and at the angle. And this leads to the formation of the peripheral anterior synechiae, and which leads to the elevation in the intraocular pressure. And there are several causes for the neovascular glaucoma. Diabetic retinopathy is the most important, followed by the central retinal vein or the branch retinal vein occlusion, and then retinal artery occlusion, ocular ischemic syndrome, uveitis, and ophthalmitis, and intraocular tumors are the other causes for the neovascular glaucoma. The treatment options available with us is the medical and surgical treatment. As I said, that it is one of the most difficult glaucoma to treat, and which I would be discussing with a case presentation. So in the management, we need a good glaucoma expert, we need a good retina expert, and we need a good physician as well to control this systemic condition. In the treatment, first we have to treat the ischemia, because this is the cause for the development of the neovascular glaucoma. And then we have to treat the elevated intraocular pressure. And if the patient is symptomatic, then we have to treat the symptoms as well. So this is a 54-year-old gentleman presented to me with a complaint of perivision in the right eye. He was a known diabetic for last 21 years and was on insulin for last 8 years, and his diabetes was still fluctuating. He was given an intravitreal injection elsewhere, once in both the eyes. He was also having an essential hypertension, and which was fairly under control. His visual acuity in the right eye was 618 and in the left eye was 69. The intraocular pressure in the right eye was 32 and in the left eye was 22. In the anterior chamber in the right eye, there were neovascularization at the iris, and the Gonioscopy, there were NVS and the PAS. The fundus shows severe NPDR in both the eyes, along with the diabetic macular edema in the right eye. This picture shows that this patient has an NVI at the margin of the pupil. And he had a severe NPDR, you can see over here, along with the diabetic macular edema. And he has lots of new vessel at the angle and with the peripheral anterior synechias at some location. This was the optic now height picture, and he presented to me for the first time. And this is after some time when I started treating, and you can see that this is the perimetry. This was the first perimetry when he presented to me, and this is on the subsequent visit. And you can see that there was a significant diabetic macular edema in the right eye. On the FFA, there were significant area of capillary dropouts, which shows that the patient has a significant retinal ischemia. So for the treatment, I put this patient on a beta blocker, alpha-2 agonist, and carbonic anhydrase inhibitor topically. And obviously, the retinal referral was taken, and my retinal consultant has given him the anti-VEGF. There is okay, anti-VEGF, and he did the extensive retinal ablation. And to control the intraocular pressure, I had to do the vitrectomy, and it subsequently failed. You can see over here. And this is the picture showing that how aggressively he did the retinal ablation in both the eyes. So, but in spite of the aggressive retinal ablation, this patient had a recurrent vitreous hemorrhage and persistent high intraocular pressure. You can see that this picture is just for a depiction, and this is not the picture of the same patient, but this patient underwent pars plana vitrectomy and with the retinal photocoagulation again and in the leftover area. But still his pressure was pretty high. I did one trabeculectomy again, And the third surgery, when I put the AGV in this patient, and then the patient has a normal intraocular pressure. This is another similar type of a patient which I had, and again in this patient also I did the true trabeculectomy, which failed, and then I put the seat on over here because to prevent the fibrosis, and you can see that okay. You can see that this patient has a significant, reasonably good bleb, and the intraocular pressure was well under control. So, in spite of treating well this patient, you can see that at the last follow-up, this was the disc picture, and this patient had a just 560 vision and a very narrow visual field left. So, in conclusion, if you have a patient of the neovascular glaucoma, you have to act very swiftly and very decisively so that the patient should not end up in this kind of a situation. Thank you very much for your patience hearing.
Thanks a lot, Dr. Prateep. Now I am going to have a question to Dr. Vinay Nandia. Is it possible for a neovascular glaucoma to clear up with PRP and anti-VEGF at any stage?
It is possible for neovascularization to regress with anti-VEGF and with laser. It's a little bit difficult to decide in which patient at what stage it's likely to regress. But if you have neovascularization of the iris and with neovascularization of the angle, but without significant degree of peripheral anterior synechia, then you may have expectations that that could work actually. So I think that's what happened in Dr. Prateep's case, that, you know, he did all the right things, but it was a kind of patient where, you know, it didn't really settle down and he had to go for the Ahmed glaucoma implant actually.
I suppose if NVG is in an open angle kind of situation, we escape rather than it goes into a narrow angle status.
Yes,
Dr. Vijaya, can I ask you this question? Is there a role for trabeculectomy at all, or it's no?
It depends upon what stage it is. If somebody who had a open angle NVG that got regressed with anti-VEGF and the PRP, it doesn't mean that intraocular pressure will get normalized. If the trabecular meshwork has been affected, and it will leave behind a defective trabecular meshwork, so you will have raised pressures. In an eye which is quiet, which behaves like an open angle, there is no harm in doing a trabeculectomy in such a situation. If there is any doubt that new vessels are still active, we do give anti-VEGF a day or two before doing the trabeculectomy, allow the eye become to quieten, and then we do the trabeculectomy. So anyway, the tubes, we keep it mainly for advanced closed angle stages.
Thank you. Paucity of time, there's a lot to discuss here, but I'm going to move on to the next speaker.